participating and sharing their information. Firstly, my name is Dr. Nicoletta Frescos. I'm from Melbourne, Australia, and I will be moderating the Western Pacific region chapter of this Awareness Week. I have great pleasure in introducing the president of DFood International, Dr. Abbas, who will be providing a few words. And then he's such a busy person, he has to move on to another country and be involved with their DFood International. It's good to be on Zoom so you can fly around the world. It's very interesting. So welcome aboard, and please, Dr. Abbas, say a few words for us.
Thank you very much. Thank you, Nicole. Thank you, everybody. I'm honored and privileged to have an opportunity to welcome you all on this 8th and the last session of the week-long campaign of DFood International flagship program of the Diabetic Food Awareness Week, which actually been running since 7th of November, and today we are having the last session on 14th of November. Today we have all gathered for the Western Pacific meet from this region. We all come together under one roof. You are all welcome. We have a keynote speaker, Professor Jeff Sussman, followed by other speakers from different countries. We are going to now present a short video, less than 3 minutes, introducing DFood International and the message. Thank you very much, and you are all welcome. Ali, can you play the video? It is an honor and privilege to address you today as President of DFood International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. DFood International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle-income countries. As diabetes rates surge, so does the incidence of diabetes-related complications, including food-related complications, which is our focus of action here at DFood International. Our mission of DFood International is resolved and clear, ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare profession are our only weapons of choice. As I often say, and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFood International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFood International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of DFood International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, B-Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you. Thank you.
Thank you very much, Abbas. It's a pleasure having you again. I think 7 days working non-stop, I think, for the whole awareness week.
Yeah.
It's 6 a.m. in UK now, I think, yes.
Yeah.
So I think with that, we have seen the key to basically wound management for diabetic foot. That means basically preventing avoidable diabetic foot amputation. Now we move to another person who doesn't need much introduction. He's been around, I think, longer than all of us, put together maybe. He's going to be our keynote speaker today, who is Associate Prof. Jeff Sussman, a very close friend of mine, who is actually Professor of Wound Care from Monash University in Australia. He is going to talk about diabetes in the Western Pacific region, the past, present, and the future. Jeff, you have the floor. Thank you. Jeff, you're muted.
How's that? Can you hear me now?
Yep, clearly now.
Yes. Good. Well, I'll start again. Thank you, Hari. Thank you, Dr. Bass. And thank you for this most generous invitation for me to present the keynote. What I will be talking about is the situation as it's been, as it is, and it as hopefully will be in the future, with a few maybe crazy or maybe not so crazy ideas I have to try and make things better. What is the issue as we see it? These are the statistics. 1 in every 10 adults has diabetes. Again, 1 in 2 adults with diabetes is undiagnosed. The statistics, as you see in front of you, are frightening, frightening. Every 5 seconds, a person dies from diabetes, 6.7 million deaths annually. And 18 seconds, a limb is lost. And as Dr. Abbas said, one of the things we have to work towards is to, in fact, reduce the number of amputations. Where are we going? Well, according to the IDF, the estimation is that by 2030, 643 million diabetics with an expenditure well over $1,000 billion, and by 45, 783 million with an expenditure well over, again, $1 and a little billion. This is frightening when we look at it. But let's look particularly in our own region, which is what we're talking about today. 29% of all adults with diabetes in the world live in our region. And China has 140 million people with diabetes. Indonesia, 19.5. Japan, 11 million. It is very, very worrying. 1 in 8 adults has diabetes in our region. It accounts for 1/3 of the total number of diabetics in the world. Again, has the highest number of deaths from diabetes. 1 in 7 live births are affected by hyperglycemia, gestational diabetes, something we have to try and change. And Indonesia has the highest rate of undiagnosed diabetes in the region. Let's look more specifically at the last few years, from 2011 to 2021, and look at the changes from 8.8% in French Polynesia to 25%, from 8.8 to 23. These figures are going up at an alarming rate. And again, China, Indonesia, Japan, all of the countries in our region are going ahead quite badly. And if we look at it at age, both in population and in what is happening, it's not a very good picture. Again, looking at impaired fasting glucose, looking at undiagnosed diabetes, looking at type 1 diabetes in 0 to 19 years, the numbers just keep going up and up. Why? We ask ourselves, why is it that we in the Western Pacific region have the highest prevalence of diabetes? Well, the fact is that Native Hawaiians and Pacific Islanders are more than 3 times more likely to be diagnosed with diabetes compared to non-Hispanic whites. Why is this so? It's due to the high rates of risk factors such as being overweight, obesity, high blood pressure, high cholesterol, and smoking. According to the CDC, people from the Pacific Islands are genetically more susceptible to diabetes than Asians or other people in the world. And again, looking at the Western Pacific and looking at what is happening, we need to really make some decisions of how we can move forward in the best way. So I believe these are the issues. The first is the diagnosis of the disease and the recognition of its complications. Then appropriate management. What is critical is prevention and how we can deal with health expenditure and costs, because as Dr. Bassler said, and I know a number of the speakers today will be speaking about, is how do we provide the appropriate management and treatment in low-income countries? And that is going to be a challenge for us. Again, in many areas, particularly low and middle-income areas, the health system isn't designed to manage to support the multiple needs of a person with diseases like diabetes. There aren't the facilities, there aren't the psychological behavioral support, there aren't the laboratories, there aren't the medication or the hospitals available to diagnose and to treat. This is a concern. Early prevention. There is a body of evidence that shows that many cases of diabetes can be prevented or delayed by lifestyle modification. And there's a lot of suggestions about targeted screening, risk factors, simple risk scores to identify high-risk patients. And of particular relevance in our region is young subjects. And I'll be talking a lot later on about the young, because I believe they are our future. And they're the ones that we should really putting our efforts in to try and do something about. The management of the diabetic foot ulcer has improved vastly over the last 10 years. Research and evidence, and there's many, many new developments that we can look forward to. But the problem is that in low and middle income countries, the healthcare system struggles to afford many of these current treatments, let alone some of the newer treatments. We need to find ways to support these countries in doing so we can minimize the serious consequences, particularly amputations. And I think DFOT International, the other diabetes bodies around the world must work together to find ways to do this. Our world is changing. We've modernized, we've changed the way we eat, we've changed the way we produce foods. We eat more and more animal fats, sugar-sweetened beverages, and there's been very few large-scale programs and policies to try and confront these dietary challenges. In its latest plan, the World Health has called for early prevention of diabetes using life course strategies with maternal health. Prospective studies have shown high risk of metabolic syndrome and obesity offering of women with gestational diabetes. We know that if a woman has gestational diabetes, if she doesn't change her lifestyle, that within 5 to 10 years, she'll be a diabetic with all the consequences thereof of that. People with diabetes need to be educated. Dr. Bass has emphasized, empowered, engaged, so they understand the disease. Research has shown that increased contact between healthcare providers and people with diabetes, regular support, reinforcement, reminders, You can't say it too often. You have to just reinforce. 20 to 50% of patients with diabetes have negative emotions. And again, it's very hard because individual countries and nationals will have a different approach to disease and to the way that disease is treated. So we have to look at that. Diabetes is an incredible burden. The impacts on individuals, families, if diagnosed, managed, or controlled. Again, there are strategies we know and understand, but because it's a non-acute, silent condition, many things are overlooked, forgotten. We're just not motivated, and governments often are not motivated. I think one of our responsibilities as well is to talk to government so that they can do something about it. Again, the updated draft of the Global Plan for Action for the Prevention and Control of Non-Communicable Diseases. This is the problem. Communicable diseases like COVID, like all of these, a lot of knowledge, a lot of emphasis, a lot of money. But the non-communicable diseases like diabetes is not seen as desperate or as critical as they really are. So we have to do things about that. Despite the challenge due to diabetes in our region, again, there are examples of where it can be improved, and we have to do this. And this is a wonderful schema which talks about what the policymakers have got to do. They must be involved. Information dissemination, health promotion, schools, screenings, reduced obesity, which results in reduced diabetes. And then the healthcare team, we who treat the patients. Again, guidelines, education of ourselves and our patients, disease management, both community care, hospital care. All of this is important because the whole aim is to reduce diabetic complications. Only 10 out of the 34 countries in our region have actually achieved indicators of improvement. Now, that's not good enough. We need to accelerate efforts to ban alcohol advertising, reducing unhealthy diets, reducing salt, sodium intake, limiting saturated fatty acids, eliminating trans fat, marketing of foods and non-alcoholic sugar beverages to children. Again, non-communicable diseases share modified behavioural risks. And again, tobacco, unhealthy diets, lack of physical activity. And that's something I'm going to be talking about a little later on. We have to do far more than we have. They're an important public health issue. Again, particularly low and middle income countries, where more than 3/4 of the non-communicable disease deaths occur. So let's start looking at our children. And Pacific Islands have a highest rate of obesity, type 2 diabetes in the world. We know this. But the study was to prevent childhood overweight and obesity, to improve health in US-affiliated Pacific regions through a healthy living program. And this was a marvelous program. And the result was the communities that had interventions showed significant improvement compared to the control communities. So interventions can reduce the prevalence of young children being overweight and obese, and therefore will have a major effect on ultimately diabetes. And let's have a look at some of the statistics again, looking at obesity and overweight. And they're not good statistics at all. So we can't ignore this with our children. We have to be proactive. So what is my plan? My plan is to educate children, covering both diet and exercise, and look for other ways to help. How can we do it? Well, it costs money. We have to find ways, whether through World Health. There are many wonderful service organizations like Rotary. Rotary has put in hundreds of $millions in works all over the world. Other service organizations to fund simple education programs in schools and community centres. And these programs can be print-based or even electronically based. Decades of rapid economic growth, urbanisation and globalisation have led to huge changes in the environment, especially in low middle income countries. processed foods with little nutrition value, but high in sugar and salt, are readily available and heavily marketed, especially to children. Unhealthy food environment negatively influences children's dietary patterns. And again, it will lead to childhood overweight, obesity, and ultimately diabetes. There are plans. There's a regional endorsed plan and a framework. And what we have to all do as member countries is to adopt the framework and begin doing something about it. And this is the schema of the framework. And I think every country has got to look at the policy framework, the multi-sectional and multi-stakeholder collaboration, the advocacy and communication, the monitoring and evaluation. If we bring these sort of programs into force, it will have a long-term enormous benefit to both our patients, their families, and to ourselves. Every child needs a healthy start. Good nutrition in childhood is fundamental, absolutely. But the problem is the harmful effects of marketing of food with high salt, fats, trans fat, free sugars is dreadful. And in our region, it's particularly bad. I have to congratulate the Republic of Korea, one of the first member states in our region to take direct government action. And I commend them. And I say other countries, look at what Korea has done. Look at the program they're trying to initiate to try and help young people. Ultimately, after restrictions were implemented, it showed food companies had to make changes, and we have to force industry to become involved. It's not just a matter of ourselves, patients and their families. We have to look at getting to industry and saying, you want to produce food? Fine. Let's produce healthy food that's going to be beneficial to our children. So I looked around to see what sort of resources are available. And there are some wonderful, wonderful games that children can play. Captain Novolin, it's been around for quite some years, and they fight against the evil donuts, milkshakes, and sodas and other sweets while making sure that Captain Novolin keeps his blood glucose in the normal range. Isn't it wonderful? They play these little games on the little Game Boys and whatevers. Wonderful. Then you've got Starbright. This again was published in '99. It's another little game of fast-paced exercises, quizzes, and little challenges. And again, the outcome is to improve knowledge and understanding and self-management of diabetes. Again, the Magi and the Sleepless Star. This is another wonderful one where it goes into a quest around the world with magical abilities to defeat the robotic enemies along the way. And kids love playing these sorts of games. So if you can find ways of providing these things, it will make a difference. The Diabetic Dog is an online game which challenges teens and young adults to nurture their pet dog that has diabetes. In other words, using the animal as the patient and having the child work to try and improve the diabetes in that patient. Again, the position statement, there is very clear evidence that if we introduce proper exercise, improves blood glucose control, type 2 diabetes, reduces cardiovascular risk, contributed to weight loss, and again, well-being, and that's important. Regular exercise can prevent or delay diabetes. This we know, but we've got to get children, and I think it's much easier than adults, becoming physically active. And there's lots and lots of studies that show that protocols can make a difference. We've got to do something about childhood obesity within our region, and there are ways we can do this. Again, there are tools that are there. We have to use the tools, find them, and be robust in monitoring the way that our kids grow up, because they're our future. Get them playing sport. Again, finding the funding through World Health, through Rugby, through the big sporting organisations. Get FIFA to donate a few thousand footballs so we can get kids playing sport within their own little communities or forming little teams. Now, let me quickly show you what we've done in Australia. This is a lovely little booklet for our Indigenous population. And it goes into what you would feel like: weak, tired, sleepy, blurred vision, blindness. Again, do you go to the toilet more often? Are you more thirsty? Are you more grumpy? Again, do you have little infections? Do you have numbing or tingling of the feet? It's a lovely, simple little booklet which we can give our Indigenous community, and it can be used anywhere in the world. The risk of smoking, looking at good diets. Again, what is healthy? Looking at your weight. Again, prevention, prevention, prevention. Looking at family members. All of this is important. It's simple, visual, basic, but blood tests, eye checks, foot checks, dentist, checking your weight, monitoring your blood pressure, taking your medication. So the future is bright but alarming. If we act now to improve lifestyle and bring down the rates of disease, and the end result will reduce amputations. We must find ways of supporting low-income countries with programs of assessment, treatment, and making resources available. We need to work with World Health. We need to work with politicians, bureaucrats, to understand the importance of recognizing and funding diabetes and diabetic foot ulcers. And only then we will end up with a better outcome. Thank you.
Thank you very much, Professor Jeff Sussman. That was quite a motivating talk. There's a big vision there, and it is so true to target the younger population, providing education program for children to prevent diabetes. And you have many, many ideas. It would be wonderful if we could collaborate and try and get some funding to implement such programs to make a change, a global change, not just in the Western Pacific region. Okay, moving along to the sharing aspect of our presentation webinar today. So the next session is the experience sharing from country members on how to make diabetic foot care accessible and affordable in your country. And we will be starting off with Professor Dr. Dato Hari Krishna Nair. If I went through all his credentials, he'll miss his plane, so I'll short track it. He is president-elect of the World Union of Wound Healing Society and the president of the Malaysian Society of Wound Care Professionals, etc., etc., etc. So please welcome Professor Hari Krishna to share his story about the Malaysian perspective. Thank you, Hari.
Thank you very much, Nikki. It's a pleasure to be here. And I have got exactly 8 minutes, because if not, Nikki will boot me out. So importantly, basically, I think we already heard what Jeff has mentioned. So it's important basically to look at our awareness week. And one of the main themes here is the access to diabetic care. Now, this Kuala Lumpur Hospital, just a disclaimer to say I work with the government of Malaysia, and basically I have got no other, disclosures. Now, this is the DFood meeting that we had basically in the ISDF, the International Symposium for Diabetic Foot, when the IWGDF guidelines was launched. The new board has just come in this year. Now, if you look at World Diabetes Day, it was created in 1991. Now, interestingly, basically, you find that it is the official day. And today is the World Diabetes Day on 14th of November. At the same time, it is the birthday of Sir Frederick Banting, who actually discovered insulin along with Charles Best in 1922. So it's a very specific day, basically. And you find that, over 1 billion people in more than 160 countries actually celebrate the World Diabetic Day. So interestingly, we are basically celebrating the Awareness Week, which is along this day. And the Western Pacific region has got the chance of actually doing this. And if you can see, basically, if you look at the blue circle logo of the of the IDF, it is actually a global symbol for awareness. And that's the topic that I'm going to cover today. Now, interestingly, basically, diabetes has become a global emergency. We're increasing by 15% now. 5% have a history of foot ulcerations. More than 25% have a cumulative lifetime incidence of this. And if you look at the Malaysian studies here, basically by DiabCare and all that, you have 78% of them who are actually not achieving their HbA1c levels. And we are supposed to get 2.48 million in 2030. However, in 2015, we have already exceeded, and we've already got the 3.3 million diabetics. This is the Western Pacific region meeting that we had, Train the Foot Trainer. Now, one of the things is about access to diabetic foot care is basically also having all our teams. And if you can see, basically, if you look at all the 7 regions, we have the most number of speakers in the Western Pacific region. Every country, about 13 countries are represented in this meeting today. And one of the things is always there's a problem with awareness. And Jeff has already alluded to the fact, education, education, education. Because you need to basically make sure don't educate only the healthcare workers, but also the others. And we talk about what we call is educating healthcare workers. We train the food trainer, which is our flagship project. And now we have trained the trainer, which is the healthcare professionals, a more shorter period so we can actually cover. Now you find that a lot of it is delayed in referrals. And this is actually found more than 52 days, basically. All right, and that's about more than 58% of them. That's a big problem, basically. That's in Europe. So one of the things from the IDF is know your risk, know your response. All right. So you need to make sure that you need to actually prevent adapting all this, prevent the delay in adapting and maintaining all your healthy habits, which has been already covered in the keynote just now. So now if you look at the DFU burden in Malaysia, now this is a study that we did with the Markov model and all that, and we found that basically close to about 1,000 over euros is being spent for just a simple diabetic foot in the government side. Another 1,500, 2,000 over euros is being spent in the private setting. And then you find that basically we have got the highest prevalence of diabetes in about 16.8%. And basically we have no podiatrists, you see, in the government setting, but more so in the private setting, there's only about 5 or 6 of them left. So the referral pathways are very important, and we need to actually do a little bit of work on that. And even our health technology assessment at the Ministry of Health does not do any evaluation of dressings. And GPs are the ones who basically are managing most of the cases, up to about 30% of them. So you find that they spend about 4,760 million ringgit basically in 2020. Now it's already gone to more than 5,000 million ringgit. So it's a lot of things basically spent on. And so one of the things is to engage the ministry, the societies, and also the World Union and the Ministry of Health, as this MOU shows. And we cover macroscopically and microscopically. Now, macroscopically, if you look at the healthcare in Malaysia, basically 70% of them are government hospitals and health clinics, and 30% are private setting. We also have those patients coming out of our pocket insurance schemes, and then you have got the social welfare sessions, plus also what you call this, the welfare part or the charity part, right? And we have a National Technical Committee, which was formed in 2009, which actually oversees all of this. And now we have got budgets for all the government hospitals and also the health clinics, a top-down approach. And we also, this is from the 10th circular of the DG's office, and we actually formed a wound care policy on that. So this is to make sure that people can access. So now we have got quite a number of hospitals and clinics altogether, basically 149 hospitals all over Malaysia in the government sector with wound care teams, and another 803 health clinics out of the 1,100 clinics which already have got a wound care team. So this covers the whole of the Peninsular Malaysia and also the 2 major states in Borneo. Now, wound kits is the other thing that we started giving, but now we also have budgets from the ministry. So we have close to about 30 billion, basically, in terms of ringgit, covering all the centers where they actually can buy their own consumables. So these are some of the kits that we used to give by the society and all that from all these conferences. And we also gave that out during the DFood International meeting. Then we have the diagnostic kits that we actually did for the 50 GPs and health clinics, because we wanted to make sure that they can refer fast. So to make sure that patients have access to the wound care unit and also the endocrinology unit at Kuala Lumpur Hospital. So this was actually done, a project which we took out, and it worked, and it's still continuing at the moment. Now, the other one is adopt a patient. Even today, we actually send off some of our staff to actually do dressings for patients who are poor, the B40 group. Now, this is actually very important, so at least they can get their dressings done at home. And public awareness and education is important. And then you talk about Safe Feed, Save Lives. Now, the thing I want to cover here is basically looking at the WhatsApp. All right. We have got a launch which covered about 1,500 GPs. We have got all the wound clinics basically involved. And also Facebook has got about 10,000 followers. Then the telemedicine model is very important so that they can connect with us. That access is very important. All right. Even if you go to Duomo, you see basically in Italy when we had the Yuma meeting, you got so many hundreds of shops So there must be many ways of actually managing this and giving access to patients. So one of the things was showing them the fast track pathway. So this was actually done in Borneo and also during the global conference. 1,000 people receive their fast track pathway cards, and we actually made them show during the opening ceremony. Then we have the certificate in clinical wound care. This is actually for the healthcare workers to actually learn more so that they can actually give good care, or standard of care is maintained basically all over Malaysia. Then you have got all the, what do you call this, magazines, you've got brochures and all that, which should be going to the patients, talking about foot care, footwear, and also managing diabetic foot ulcers. So it is endless. We can never, what do you call this, stop working, because it's a lot of things to be done, even in terms of foot assessments and everything else. So it's a big project that has to be continued. And then don't forget, even AI is important. So we have got all these basically tablets, phones, and all that, where patients can contact us. I get referrals from Facebook, from LinkedIn, from Instagram, and then even from WhatsApp, Viber, WeChat, all kinds of funny places. And basically, what we call this, we still entertain all of this because patients have that access. So what is the most important here in terms of raising awareness? So at policymakers, Ministry of Health has come up with this Madani Healthcare, whereby they're going to give budgets to what you call is the GPs and all that, who will be able to actually see these patients, and they get a budget from the Ministry of Health for at least the consultation. And then at the same time, for education and training, we have got the postgrad in wound management, we've got certificate in clinical wound care, we have got the ADNAP programs under WCET, and we have now started the caregiver module. And then in terms of AI, we're also doing modular work in terms of basically what they call this, a platform, a digital platform. So networking is the same thing. So we have got all the societies coming in, and that networking is very important to share all this. And with that, basically, this is to show you what they call this, the Armada is ready, and the Western Pacific region is ready. So this is actually important for us to prepare for launch, because even under the World Union, we have got 4.7 billion people in Asia Pacific region. So we need to actually, what we call this, go out all out and actually do this. So with that, thank you very much. Okay, now we move to the next country, basically. I'm sorry, we go back to A again, and we go to Australia. So here we have got Nikki Fresco. So we're doing a lot of work, basically, and together with Professor Stephen Twigg, who are basically our representative from Australia. Nikki is actually a podiatrist with a PhD and what they call a specialization into pain management. And she's with La Trobe before this. And she will actually, what they call is, present to us on access to affordable diabetes in foot care in Australia. Nikki, you have the floor. Thank you.
Thank you very much. Can I just clarify, what exactly are you seeing on the screen? Just one big picture?
Yeah, with the access to affordable diabetes foot care in Australia. The whole thing is here.
Beautiful, beautiful. Thank you very much. So if I go back, thank you for that introduction. And I am presenting on behalf of my other two colleagues who are part of the DFoot International, and that is Professor Stephen Twigg and Georgina Frank. We seem to be representing Australia on many occasions, and they're a delight to work with. So the topic, well, I took it to heart as to what the topic was. So I will be talking about access to affordable diabetes foot care in Australia that has developed since last year. So I will be telling you and sharing stories of up and coming projects that are being implemented into Australia. So I'm going to take you back a few years. Diabetes Foot Australia is a organisation that is totally focused on prevention and care and support and research for diabetes foot disease in Australia. And they developed a 4-year strategy plan beginning 2018 and to 2022, with the aim of that this strategy plan was to be the first step towards ending avoidable amputation within a generation, so to 2040. I mean, that's a huge dream, but we're aiming for it. So there were 3 key priority areas and strategies, and that was access to affordable and effective care, and that included the medical benefits scheme for annual screening, high-risk foot adding high-risk foot clinics, supporting funding footwear and insoles, offloading devices and wound dressings, and also aiming to provide interdisciplinary foot disease services, specifically in the regional areas, because we are lacking in that. And Australia is very big, and services within the city areas, there's several of them, but as you do go out into the rural and regional areas, there aren't many around there. So it's really important that we access the rural and remote communities of Australia. The second priority was provision of safe quality care. And under that, the strategy would be to develop training modules for healthcare professionals, developing credentials for diabetic foot disease professionals, and a register, and also accreditation of the interdisciplinary foot services. And in addition, creating national guidelines. And the third strategy is to development of the research to improve patient outcomes. So I have great pleasure, and I'm overjoyed that the Australian government this year actually took note of these strategies. So with priority 1 of the DFA strategy plan, highlighting access to affordable and effective care, the Australian government actually provided in this year's budget, 2023 to 24, some great news for people living with diabetes. And what they've done is they've put funding towards specifically chronic disease management reforms for people living with diabetes. So that's increasing patient access to underserviced areas. So that's using the medical benefit scheme. They are developing a chronic wound consumables scheme. So this is where wound products, dressings, etc., will be subsidised by the government, and that's really important for us in Australia, because there is no funding for wound dressings. Everything has to come out of the pocket of the patient. My Medicare is a government a funding system for people to see their doctors. So there will be a greater funding package for people who require greater support and have more complexities with their diabetes. So that could be a multidisciplinary package for their care. And then there's a multidisciplinary team, so increasing the support of primary care practices in the underserviced areas and increase and improve that management. So here it's more the development of multidisciplinary teams in the regional areas. So this is where I'm excited. $47.8 million will be delivered over 5 years to establish a chronic wound consumable scheme. So this will cover the cost of wound products, dressings, etc., used by eligible people who have chronic wounds that are due to diabetes. So once that $47.8 million has been used to establish the scheme, it is planned that $12.3 million per year will be ongoing funding. And that's champagne, that's, excitement, really, because this is the first time the government has paid attention to the needs of people with diabetes foot disease and, the cost to the person themselves, not only quality of life, but, financial cost. The eligibility for being under the wound consumable scheme is that it is open to all people with diabetes over the age of 65 or 65 and over, and also the Aboriginal and Torres Strait Island Indigenous Australians with diabetes aged 50 years and over. So this is really, really important. I'd like to mention that the Australian Medical Association was very proactive in putting submissions towards this, and so was Diabetes Foot Australia. So how is this going to come about? The subsidisation process, what's going to happen is that the government will establish an expert advisory group, and this group will then look at the range of products that will be subsidised. They will conduct or they'll contact the market to determine exactly what wound products should be available in this scheme. And also, how will this will the wound products be able to be ordered? So they're looking at an online wound product ordering system by particular company Services Australia. So the proposed system will be that the healthcare workers who are caring for people with diabetes will be able to order the products online and then deliver them to the patient's home, or they will use them when they come in for the consultation for wound care management. It is proposed that this scheme will commence in May 2025. In terms of the priority 2 of provision of safe quality care, that funding from the government that was allocated would also be developing training and education programs for healthcare clinicians. So that's, again, great news, because we need more and more of this. Currently, there is an official university course that it provides postgraduate training for healthcare professionals, and also to the master's degree from Monash University, where Professor Jeff Sussman is from. However, that is paid for by the healthcare practitioner. But the government is proposing to develop programs that is accessible for all healthcare professionals to be able to be trained in diabetes foot disease prevention. The credentialing has been slowly occurring through Wounds Australia, but it hasn't quite developed. But we do have credentialing of the multidisciplinary teams, which creates accreditation, and there's a rigorous process in getting that accreditation. The national guidelines have commenced, so that's not related to the funding, but kudos to Diabetes Foot Australia. They redeveloped, in a sense, the International Working Group Diabetes Foot Guidelines and adapted them to the Australian context. So not everyone can fit into that international guideline. We need to modify it to suit our conditions, to suit the country's conditions. So that is established. A new funding, new initiative was the development of the Australian Centre for Accelerating Diabetes Innovations for Research Centre. And this is another great government initiative. This started about a year ago, and it is developing into a research hub. To basically, what it's trying to do is provide equity for diabetes-related healthcare with newer initiatives, newer products, more research in the area. And their priority areas are the diabetic kidney disease, peripheral neuropathy, and diabetic foot syndrome. In particular, there's a fair bit of money specifically for peripheral neuropathy, which again is quite exciting. And the third research area is short-term complications of hypoglycemia and or hypoglycemic syndrome and ketoacidosis. Other projects or innovations that have developed since last year. We were fortunate, well, Australia was fortunate enough to obtain a grant from the Ergo Foundation, and this was submitted by Interplus, which is a non-government organisation who provides health services to Asia Pacific, or specifically Pacific areas, teaching doctors and nurses on various aspects of healthcare. And since I've joined Interplus as a volunteer, it has put a focus on diabetes foot care. So it was really good that Interplus was successful in obtaining a grant. And what they did was develop 2 educational videos. One is on diabetes foot screening and prevention of amputation, and the other one is on offloading and foot care. So these resources are available free through Prax Hub, and they are targeting the Pacific Islanders. prior to that project on specifically for diabetes foot disease, other resources that have been developed by Interplus educator volunteers involves wound management. There's wound debridement webinar, there's wound solutions used in the Pacific regions, and there's another short 3-part series on diabetic foot disease. So there are resources that are accessible freely to anyone, and it doesn't matter what part, what region, whether you have resources or not, these are accessible to anyone. So feel free to register and log into the Prax Hub to obtain those, and they're targeting nurses and doctors in the education. So I am excited because in the last year we saw a focus of the government on diabetes foot disease, which it took a long time, and I can only see great improvement for services for people with diabetes, and improving access to care, quality care, and funded and supported by the government. So I'm rapt about that, and thank you for listening to Australian Progress.
Thank you very much, Nikki.
I need to stop sharing now. Here we go.
Okay, thank you very much for sharing your experience with us. I see that Australia has been a lot ahead of many countries in the region. You have a good strategy and you work very hard for that. Thank you for sharing with us. The next we will move to China, the country where we have the highest number of diabetes in our region. Professor Dr. Wu Quantum.
Hi, Dr. Lupa. Very nice to see you. And so very nice to meet every colleague online. So let me introduce what the situation for the patients with diabetic foot in China. So now we know that today is World Diabetes Day. As the doctor just mentioned that the China is now the first population of the diabetes patients in the world. So the not just the population, the people in the world, like in my living city, we have the million people living in my city. So there are lots of the patients with diabetes. So let's have a look at the news reported today. So there is lots of the patients because of diabetes lose their feet. About the 218,000 patients lose their feet every year. So it's a very big problem for the patients for the diabetic foot in China. So let's have a look. What did we do? So about 8 years ago, there is a national investigation of about the diabetic foot in patients with diabetes. We can see that here about the patients, how much. Let's have a look. Here we can see about the patients, 19.03% of patients has amputation, over the amputation rate. And there is a major amputation about the 2.14%, and there was a minor amputation about the 16.88%. So even this is 8 years ago investigation survey, but we can see that it's a very huge problem for the people with diabetes. So what did we do? Like today, we have under the patients with diabetes and help them. Today, this is my working hospital in the morning. So what did we do for the World Diabetes Day today? So we tell the people how to prevent about the diabetic complications, and tell them how to monitor your blood glucose and so on, and tell them how to inject the insulin and so on. So lots of the sense to the people with the diabetes. So there's a difficult for the diabetic food management in China. The people, they should more awareness, more safe for the patients with diabetes. So let's have a look what happened in China about the patients with diabetes for the amputation prevention. This is, during the COVID-19, almost no people on the streets. But, after the COVID-19, ending the COVID-19, the people with diabetes, all of them almost have very severe, like the food infection and gangrene, lots of the different very severe complications for the food disease. Let's have a look, lots of them. And some of them, after the amputation, they cannot heal. So maybe they did more the amputation, and lots of people like here, the gangrene, lots of them, and this is a shock food. So because of the COVID-19, the patient has delayed for admission. Like these patients with very severe, the infection, not just on the food, we can see on the head, they also has the infection. So the people like this one, they all, because of the COVID-19, they delayed for, ask a patient, ask the doctor to treat the wound, and then we can see they had amputation. So this is so based on the patients with very severe diabetic foot disease. So we also have MDT. The MDT not just cell with foot disease, they also cell like the patients with the systematic the problem, like sepsis and like some infection in another organs. So here we can see patients with very severe infection on the neck and the foot. You can see over here, this have a gas infection. So after lots of the different surgery, and we help the people save his life, and also they save his fate. Also, we can see these people, they always very severe the foot disease. They, after the debridement and some resection some of the bone, and we get them in the skin, flag, and transplantation. And then we, and save the fate. So what I have done for patients with a healed diabetic foot after discharge. So we also education people with a diabetes. Actually, they don't care that, there are too many people with a diabetes. And now, the China, like in my living city, the food is much more delicious. They don't like, know how to, for the diet. So they also have different health problem. We can see we also education the people with a different, like in China, we use WeChat. So we have the WeChat group, and then the people educate them in every week. So we also, educate the diabetic patients through the TV and with some different video. So we record the video and told them so how to do your everyday life and how to take care of your food. We also, like me and another doctor in my department, so we do lots of the work and like through the TikTok, the Chinese version of the TikTok, we told them how to, prevention of the amputation for the food. So we also, lots of the education program for the people in the different area. At the same time, also training the physicians and community health service center. Like here, we not just education the patients, we also education the physician in the community, the health service center. Let them know what's the dangerous, what's the risk factor of the diabetic food. So we also, establish lots of the training, the conference in the health service center. So, and we also tell them some very useful tool, like told them how to uploading the people with diabetic food, like this patients with very typical neuropathy diabetic food ulcer, and before they don't know how to deal with this situation, but after we training the patients in the community, the service department, they know how to offloading. So in my department, we also tell them and how to do offloading the people with different that one. So this is a shackle food. If knows the foot the special the footwear, they cannot stand up, they cannot walk. But now we tell them and they can use a special the footwear, they can stand up and walk like this. Yeah, this is our work for the patients. So this is a regional action to against the diabetic foot amputation. So what did we do in China? Regional action to against the diabetic amputation. So in the CDS, we have delivered a handbook for the patients and for the doctor in the community hospital. Tell them how to diagnose and treatment of the diabetic foot. So we finish that, and in additional, we also have the expert concerns to diagnosis and treatment of the diabetic foot by the CDS. So tell them how to do diagnosis and treatment of the diabetic foot. Also in this year, we use the traditional Chinese medicine. So we also delivered a new the guideline for the diagnosis and treatment of the diabetic foot with traditional Chinese medicine and Western medicine together for prevention and treatment of the diabetic foot. Except that, we also delivered another the clinical pathway for the treatment of the diabetic foot in China. This is a very new version for the diabetic foot treatment and prevention. So we can say different department of the China. We can say Chongqing is my work in the city. We based on the emergency network and establish a new model from the family to the community health service center to the diabetic care center. So we have a loop and together to treatment and prevention of the diabetic foot. And Chengdu also is the southwest of China. They also, funded a different education program to education the doctor in the community hospital. And this is southwest action to against the diabetic foot amputation. This is Shandong, eastern of the China. We can see north of the action to how to prevention of the diabetic foot. This is Wuhan, the middle of the China. They also training the foot technician and the nurse to how treatment the patients. They have lots of the programs in the last year. This is Changsha, like almost southwest of the China, lots of the different action. Shanghai is the eastern of the China. They also has like the vascular surgeons in Fudan University. They did lots of the work. And in this year, except for the clinical practice, we also focused on the study like this. The diabetic study in China, we can see in the past year we have 329 the papers published for the diabetic foot. There are also the 7 papers in China. We also communicate with different scholars from different countries. This is South Korea, J.P. Hong. This is my mentor, Dr. Armstrong. And this is Andrew Burden from the UK. And this is David. Meet him in Singapore this year. And this is, in Malaysia, we meet everyone. So this is also my hometown. So I want to say, I really don't like the panda, not too far, and prevention of the diabetes. This is the first step to, prevention of the diabetic foot. So that's all. Thank you for listening.
你好，係陳係㗎，我姓陳，點解咁咧就
Hey, Samson, your microphone is on. Please turn it
OK
off.
嗱，唔好意思啊，我就話即係我呢個就睇咁啊，就話啲真係好骨係嘛咁啊幾時啊？前2日咁啊
You, Samson Chan.
咁啊有
That's
Okay.
it's
Thank you
not
very much, Professor Tung, for your sharing with us. It's amazing work. It's very difficult how, I mean, if you think about huge land of China, huge number of patients there.
right.
But
See,
anyway, it's amazing what you have done. I've been
see.
traveling to China like once or twice a year in the past few years, and I'm impressed with the progress of China in the work on diabetic food care. Thank you very much for sharing with us. Okay,
Okay,
the
thank you.
next speaker, I'm very happy that we have some new member this year. So the next will be Fiji by Shivali Ranchika. The floor is yours. Please share your experience with us.
Hi, everyone. I would just like to apologize in advance if there's any connectivity issues from my side because we are experiencing adverse weather conditions over here, due to which the internet might be a bit poor. Share my screen now. Okay. Can you all see my screen?
Not yet.
Yeah.
I see your
Okay.
face, but not the screen.
You see my face and not the screen?
Because face we can see, but your screen we can't see. Shivali.
The previous one will have to
Oh,
Because
you
unshare.
can't see me?
until we click the
Professor-
Oh,
share.
stop sharing.
Ah,
Okay.
beautiful.
Oh,
Yes.
Good. PG.
all right. How about now?
Yes,
Okay.
yes.
Shivali,
Good.
okay. It's coming now.
And it's not on the presenter view, right? It's just a slideshow view.
Correct. It's a slideshow.
Awesome. All right. All right, I'll begin now. So thank you, DFood International, for giving me this opportunity to speak at this Diabetes Awareness Week event. And good day, everyone. My name is Shivali. I am a podiatrist based here in Suva, Fiji. And I am delighted to present this topic to you all today. So the topic for today is how to make diabetes mellitus food care accessible and affordable in Fiji. All right, so this is just a brief overview of what content will be on each slide of this presentation. And I will start by talking a little about Fiji and about diabetes and food care in Fiji, then some barriers and challenges faced with diabetes food care, followed by solutions and prospects, and then a small conclusion. So let's get right into it. Okay, so in this slide, I will be introducing you to Fiji's geography and population. So Fiji is a country, an archipelago located in the South Pacific Ocean. So this archipelago, it comprises of about 300 islands. And the two main islands are Viti Levu and Vanua Levu. So Viti Levu is the largest island, and then Vanua Levu is the second largest island. So Fiji, it has a population of close to 1 million people. And with its pristine beaches, crystal clear waters, and beautiful landscape, Fiji is a popular destination for tourists. However, like other developing countries around the world, Fiji also faces issues of health crisis, such as non-communicable diseases. So these NCDs, they have a high prevalence rate here in Fiji, more specifically diabetes. So diabetes, it poses a significant health concern in Fiji, affecting a larger portion of the population, and the numbers, they continue to grow. So in 2015, according to the Fiji Ministry of Health and Medical Services, about 30% of the country's population had diabetes. So that's 1 in every 3 Fijian. And the type 2 diabetes mellitus was common compared to type 1 diabetes. And as we know, one of the most critical complications of diabetes is the impact that it has on the feet, causing complications like peripheral neuropathy, diabetic foot ulcers, diabetic foot infection, and even amputations, and so on. So moving on, the lack of awareness on the prevention and management of diabetes and its complications, including the importance of foot care, are responsible for the high rates of amputations in Fiji. And it was stated in an article, a 2015 article by Morgan, that Fiji was dealing with the highest rates of amputations in the Western Pacific region at that time. So therefore, it becomes imperative for patients to know how proper foot care practices plays a crucial role in preventing these diabetes-related foot complications, and how it also reduces the risk of or also prevents lower limb amputation. Moving on. So again, Fiji as a developing country, it does have several barriers that hinder the effective management of diabetes, its complications, and proper foot care practices. So these barriers, they significantly impact the health and well-being of patients, making them more susceptible to diabetes-related foot complications. Anecdotally, a significant proportion of Fijians are at a disadvantage when it comes to health-seeking behavior, and this is due to geolocation barriers. As a significant proportion of the Fijian population, they live in rural, remote, or maritime districts with limited or nil access to healthcare facilities and services, as comparable to those accessible to people who are living in the urban areas. And then visiting healthcare facilities for regular checkups, it does require transportation. While public transportation such as buses, they exist, it may not be readily available for roads and infrastructure. And then high costs for private transportation, such as private vehicles, taxis, and carriers, which are like vans, they pose as a financial burden for individuals with limited financial means. So this then leads to missed appointments and lack of follow-up care. There was this study done in Vanua Levu in 2020 by Kumar and Mohammed Nezad, and this study, it stated that financial difficulties was one of the socio-economic factors affecting patients with the self-management of type 2 diabetes. And then this poorly managed diabetes, it resulted in a lot of complications. Now, limited resources as well in terms of medical supplies, it also impedes proper foot care. And although patients are getting free medication from pharmacies under the free medicine scheme, sometimes the stocks are low, which means that patients may not have constant supply of a particular medication to manage their medical condition. And there's also a shortage of dressings for wound care and lack of specialized footwear and offloading devices, all of which I think affects the proper delivery for treatment of a diabetic foot. And then due to the lack of or due to the limited resources, patients may resort to other means of treatment, such as the use of herbal medication. And then again, the traditional beliefs and practices, it sometimes conflicts with the medical advice, leading to reluctance in adopting modern foot care practices. There is also a lack of knowledge regarding diabetes foot care. So many individuals with diabetes are unaware of the potential risks, the preventive measures, and the importance of foot care. And this unawareness, it acts as a barrier which prevents these individuals from taking proactive measures to protect their feet. So, and there are some patients with diabetes who also fear amputation, and due to this, they present late to clinic for treatment and care, and this again causes further complications as the foot problems have progressed to advanced stages. And then it becomes challenging to manage these advanced conditions conservatively. Okay, now improving proper diabetic foot care in Fiji, it does involve addressing these various barriers and implementing effective solutions. So by involving the community, the healthcare workers, create awareness, they promote preventive measures and ensure better adherence to treatment protocols. Even conducting community workshops involving local leaders to educate community members about diabetes, its complications, and the significance of foot care. Then useful information can also be disseminated via media such as the radio, television, and social media platforms, and even training local community health workers to educate the community members about diabetes mellitus, the diabetes-related foot can also be done. We can also empower these community health workers to conduct home visits and follow-ups to ensure that patients are adhering to their foot care routines. So this image on this slide, image 7, it is an article about a study that was conducted in 2020 by Jiang et al., which found that community-based self-management group interventions for patients with diabetes, it had a long-term effect on improving the self-efficacy of patients. And this therefore indicates that strengthening and creating awareness in the community does have its positive outcomes. So there are teams, some NGOs such as Diabetes Fiji that are involved in visiting rural, remote communities for community engagement outreach programs. They're also conducting home visits and providing services such as screenings, assessments, and necessary treatments on site. And this improves the accessibility for patients and allows for early intervention of medical conditions. There is also telemedicine available, which allows patients talk to their healthcare professionals remotely via phone calls, videos, and text messages. In some cases, this also allows patients to have follow-ups from the comfort of their own home and without the need to travel long distance, hence improving accessibility. Moving on. So in April of 2022, the Ministry of Health and Medical Services, they launched the Reformed Free Medicine Program, availability of key medications through the private and public pharmacies to citizens with an annual income of below $20,000. So there is about 140 medications available through this program. And patients registered under this scheme can present their prescriptions at private pharmacies, and then they can get their medication. And the private pharmacies then redeem the monetary reimbursement from the Ministry of Health and Medical Services. So there's also a free health scheme, which has been introduced by the government to strengthen Fiji's healthcare system. So this scheme with a combined household income of $30,000 or less to have free access to private general practitioners, private dental practitioners, and medical center hospitals. Materials, diabetic foot care products, and maybe even footwear, can also be in the free medicine program. This then maintain good standard. Collaborations and partnerships between NGOs, private and public health sectors, relevant stakeholders, government agencies, and international organizations. It also helps to address the challenges associated with the diabetes foot care. So Diabetes Fiji Inc., an NGO based in Suva, Fiji, they partnered with the Ministry of Health and Medical Services in 2013 and rolled out a project to strengthen diabetes care and promote diabetes awareness through the support of World Diabetes Foundation. And through this project, Diabetes Fiji has provided training to healthcare professionals such as nurses, physicians, physios, etc. in diabetes food care. This organization, it has also established food clinics and provided basic equipment for diabetes food care to these clinics. Now, there are diabetes hubs here in Fiji. So there has been a setup of 3 diabetes hubs within Fiji. And these hubs, they provide free diabetic care to patients, including free diabetes screenings, diabetes foot assessments, diabetic foot ulcer care, wound care. And each diabetes hub, it consists of doctors, nurses, nurses who are trained in foot care, have dietitians, visiting physiotherapists, and the admin staff. And I believe that with the right strategies and continued collaborations, Fiji does have the potential to expand diabetic foot care, leading to an improved overall public health and well-being. And this is my last slide, concluding this presentation. So while there are challenges in accessibility and affordability, I do believe that Fiji's prospects for improved diabetes food care are encouraging. And by building on the existing initiatives, fostering partnerships, embracing technology, and prioritizing education awareness, Fiji can significantly improve the accessibility and affordability of diabetes food care services, ensuring that all patients with diabetes, regardless of their location or their socioeconomic status, they have access to essential food care treatment and preventive measures. And this creates an improved quality of life and ultimately reduces diabetes-related food complications. And there we go. Thank you all for your time. I now invite any questions or thoughts you might have.
Thank you very much, and welcome to our group. Hope to see you again next year. Nikki, I know that you have involved in some work with them in the past. Would you like to make a comment?
Shivali, congratulations. I'm so excited that you are a podiatrist in Fiji. Are you the only one?
I believe so.
Well done. Well done. That is a huge move, and you've provided a great overview. And from the time that I was trying to, push for podiatry, you have gone a long way. So congratulations on all the wonderful work that's happening. And I can only see it's going to get better and bigger, and you're going to have a lot of work to do. So well done.
Thank you so much.
I'm so proud of you. I'm really, really proud of you. That's fantastic. And welcome to the group.
Oh, thank you so much.
Yeah, thank you. Now let's move to another island country, Hong Kong. Professor Samson Chan, please.
Can you hear?
Yes.
Hello?
Yes, we can hear you.
Okay, yeah, let's gonna present. Okay. Okay, so nice to see you, everybody. I am from Hong Kong. I'm Samson Chan. So can you read my presentation?
It's not up yet.
Not yet.
Not yet.
Is it?
Not yet.
Can you the presentation?
No, we cannot see it. Maybe you can
wait a minute.
Okay.
叫等一陣啊，係咪？我記得。Hello, yes.
Did not see Samson.
Yes.
Yeah.
Hello. Hello, can you?
We can see you, but we cannot see your PowerPoint slides.
So we can hear from you, but we cannot see slides, right?
Okay, let me do something.
Samson, can you make it?
Okay.
Samson, or you can send the PowerPoint file to me. I can share the screen for you.
Mm.
Dr. Samson, can I move to the next speaker and we'll come back to you after this?
Okay. Can you read it? Can you read the slides now?
No, we cannot see the slide.
Not
Oh.
yet. Maybe the last speaker not ending the screen.
Samson, may I move to the next speaker and then we'll help you manage with the slides and then we'll come back to you after that.
Yes. Yes.
Okay, let's move to the next speaker and we will come back to Hong Kong later. The next speaker will be for Indonesia. Dr. Adi Wildan, please.
Thank you, Prof. Wilbert. Is my slide and my voice clear?
Yes, we
Yes.
can see your slide.
Yes.
Physiology, Metabolism, and Diabetes Division, Department of Internal Medicine, Faculty of Medicine, University of Indonesia, and Cipto Mangunkusumo General Hospital. I'm here in behalf of our institution and our seniors. We'll talk about enhancing quality and accessibility of diabetic food care in Indonesia. As already stated before, diabetes is still a very big problem in Indonesia. Right now, 1 out of 10 Indonesian adults living with diabetes, and it's approximately around 20 million people with diabetes in Indonesia, and most of those are undiagnosed, around 68%, and 70% of them are uncontrolled. So those undiagnosed and uncontrolled population have high proportion of chronic complications. And unfortunately, around 1/4 of the people with diabetes is under 45 years old. So they have a long life ahead of them, and they will be faced with increased chance of complications. Regarding the national data of diabetic foot ulcer in Indonesia, as you can see here, Indonesia is the world's largest archipelago. We have a total area of 1.9 million meters square with approximately 17,000 islands with a population of 273 million. And we have more than 500 ethnic groups and languages across the country. So as you can see, it is very hard to collect the national data of diabetic foot because our area is very big and we have a lot of small islands. So the distribution of facilities and also the doctors and nurses are not equals among the islands. And there is no national data, but each center has their own data ranging from 5% to 24%. In our hospital, Cipto Mangunkusumo General Hospital, which is a national referral hospital, about 1/3 of the patients with diabetes were hospitalized due to diabetic foot ulcer. Those patients were associated with longer hospital stay, higher amputation rate, and also ultimately higher cost. Especially during pandemics, patients had higher number of osteomyelitis and major amputations. So we conduct our clinical audit on diabetic foot ulcer. We only use 6 criteria because this criteria will also be implemented in across Indonesia. So this 6 simple criteria is about the diagnostic process, which is comprehensive physical examination and laboratory index, and then the therapeutic process, which is comprehensive wound care in 24 hours examination, and also giving metabolic control. And the output is improvement of infection in after 4 days and not amputated. Here you can see that the number of amputation is high, which is 41.8%. We do 5 why analysis with the what is high amputation number. And the way number 1 is patient with diabetic foot ulcers who come to Cipto Mangunkusumo often are already in advanced stage because the foot care at previous healthcare facilities was less than optimal, and patient delayed seeking treatment at previous healthcare facilities because they are not totally aware of the complication they are experiencing. And also, patient already have too many comorbidities and complication of micro and macro angiopathy with long-standing hyperglycemia, so they have no symptoms. So, and because they have poor knowledge and therefore poor glycemic control. So the patient usually came already too late to the healthcare facilities. And we do the fishbone analysis in our hospital. From the patient side, there is a delay in the referral because and patient also have multiple comorbidities. And it's also because the patient delay in seeking help because usually they have no symptoms and they try to take care of themselves first by themselves. And then after it's not working, they try to go to the hospital. And then for the service provider, we have medical team readily available with multidisciplinary approach. And then for the service process, we have hospital guidelines. And for the facilities, unfortunately, we have a long waiting list for CT angiography and also a waiting list for operating room, especially in the emergency room, where diabetic foot ulcer patient usually has to wait for the operating room, and there will be other diseases usually will be more than 24 hours. And this is also a very big problem for us. There is an inadequate facilities for diabetic foot shoe. So around 54% of the patient with ulcer will readmitted because of the ulcer because we do not have enough facilities to make diabetic foot shoe. And for the cost, real cost is higher than the government insurance paid. So usually the patient has to go home first and then readmitted to the emergency room to do the next step like surgery or maybe other vascular surgery. So because of this, Ministry of Health appointed our hospital as the national leader for improving diabetes care in Indonesia. And Cipto Mangunkusumo will lead other 14 regional hospitals, which in turn will have their own hospitals to improve. So we'll maybe you can call it a multi-level marketing. And one of the effort is using those clinical audit on diabetic foot ulcer as a national level clinical audit. So we can see how the care of the diabetic foot ulcer in each region, and then we can try to improve from there. And this is the 14 hospitals. As you can see here, it is spread across Indonesia from Aceh in Sumatra, Ada Malik in Medan, and then M. Jamil in Padang, in Palembang, and in Java, and also in Sulawesi, we have in Manado and also in Makassar. You see here the color is the color of the provinces that this hospital is responsible for. As you can see here, Cipta Mangunkusumo is in pink. So we are responsible for the one in East Kalimantan and also in Papua. So we will lead around 10 to 11 hospitals, and we will improve their knowledge and also their skills. And then these hospitals will oversee the hospitals under their area. And also because it is a very big project, it is not only under the Ministry of Health, but we will also involving the local government to provide the budget for the improvement. And this is our diabetes care stratification for improving the diabetes care. As you can see here, we also included the basic diabetic foot care, and then vascular intervention, and diabetic shoes and prosthesis. We hope that by using this as a mandatory project, the hospital will improve their care and also their access to the diabetic foot care. And this is the documentation of our training program. This is our nurses. And usually we have routinely for once a year, we do the training for the healthcare providers. And of course, this is if there are many requests, we can do the training more than once a year. So for the conclusion, diabetes and diabetic ulcer are still a large problems in Indonesia. Most of the DFU patients did not get proper treatment and usually came with severe infections. Efforts are being made by the Ministry of Health with diabetes partnership with the RSCM and also 14 regional leaders. We hope we can improve diabetes and DFU management across Indonesia, aiming to enhance both knowledge and facilities in regional areas for improved patient care. I think that's it for my presentation. I hope it can be beneficial for us. Thank you very much.
Thank you very much for sharing your experience with us. I just feel that, in our region, we have so many island countries. Geography is a real problem in our region as well. Thank you. Samson, are you ready? Okay. If not, maybe we move to the next speaker. The next country will be a new face also. Welcome, Dr. Bote Promin from Laos. The floor is yours.
Okay. Did you see my screen?
Yes, I can see the screen.
Okay. Good afternoon, everyone. Thank you so much for inviting me to join this meeting. So since today I have a 3 meeting, so I have to go fastly. So, okay. How to make it? Okay. I will move my slide. Okay. Okay. This is the map of my Lachlan country. As you see in the different color that show about the statistic of the diabetics in 2005, but today is coming grows up or increase more. This is the activity, the first activity that I joined in 2018 at ASEAN level. Then the next one is global level, that you can see it. This is the gift that offered by Professor Hari that I distribute to Central Hospital. After my 2018 event that I attend at ASEAN and at Global Wound Care, when I back home, I start to develop the small project that support by ASEAN Wound Council and support by Professor Hari as the international technical expert. We involve the more than 100 people around the Ministry of Health and Central Hospital, nurse, doctor, surgeon, endocrine, and lecturer from university to be our attendee. This is a WHO ranking in 2020. The total death by cause. The diabetic is number 8. Leading cause of death in Laos, diabetics is number 6 among 50 diseases. This is the information exactly to the diabetics. The death cases is 1,460, then 3.634%. Then the world rank is 21. Now I'm presenting about the wound care in DM in Laopedia. In my country, we have 7 central hospitals, 17 provincial hospitals, and 148 district hospitals. Sethathirat Hospital is one of the 7 central hospitals in Vientiane City. This hospital took a role for teaching medical students and others. The hospital created This hospital created a specific department of endocrine and take care about the DM patient with the diabetes. The report from this hospital, totally the department have only 19 members, which include the doctor, endocrine surgeon, cardiologist, general nurse, and other staff. The number of the patients coming to services in this department average 1,500 a year. The OPD case who circulate from January to July 2022 is only 42,000 times. IPD 25,000 times. Follow-up wound 175,000 case only. This is a picture of DM ulcer. This is a picture of DM ulcer. This is the team for wound cleaning. This is the OPD cases. This is the IPD education. This is the bedside teaching. This is the bedside teaching. Now we are sitting together for talking about the one that we have done at Central Hospital, 7 Hospital. So as we see, the community education is the priority awareness and concern that we have to do. Good response from the community. They are involved more than 100 people. The one that I show you is the city, in the big city in Vientiane capital. But how come in the community? Now I'm going to show about one of the 17 provinces. Luang Prabang province is World Heritage province. This data has shown is the statistic of the DM cases in this province. What are the problems inside this province? Luang Prabang province is no DM unit. The service include the under control of the internal medicine. No analysis of HbA1c. Medical staff for DM care is not enough. The DM knowledge in some medical staff is not enough. Patient information for DM is not yet profound. Patient lack regular follow-up. Patient use traditional medicine and buy the medicine themselves. On most of the DM come to see a doctor when they got the complication. For example, foot ulcer that they cannot treat themselves, neuropathy, for example. Community education is seen to be simple, but is the big challenge between inside that. There are 5 big challenges. The first one is behavior and culture eating. As you know, sticky rice is the main priority meal in my country. Spicy and salty. Second, less awareness on the DM control and nutrition. No education to the community. No workshop for nurse training on DM wound care. Financial support for the DM activity still limited. The planning for future, we have 5 planning. Improve knowledge of DM complication in community. Second, develop training tools for community education with different language, because we have 48 ethnic language, but the main priority that we have used is more than 5, between 5 to 6. Hmong, Kimmo, and Akha, for example. Third, stringent healthcare for the aim at hospitals. Fourth, require international support for the workshop on the DM wound care. The last one, develop program for international support for the DM activities. Thank you so much for your attending or listening. Thank you.
Thank you, Dr. Bokdep, for sharing your lab experience with us. I'm sure together we can make us all together, I mean, growing up together. Thank you very much. And also
Thank
welcome to the group.
Thank you.
Samson, Dr. Samson, can you make it? Okay, maybe not yet. So the next speaker, we will move to who's next? Okay, Harry did that already. So the next speaker will be from Myanmar. Professor Kim Myo-han will be a presenter, please.
Hello to all. Can you see my presentation? So, thank you to Diabetes Food International giving the opportunity to share our experience how to make diabetes food care and affordable and accessible in Myanmar. In this presentation, Professor Myadong share his experience regarding hospital, and I will share my primary care experience. In Myanmar, there's a 55 million population and 8 major ethnic groups, 135 minor ethnic groups live throughout the Myanmar. For this community, our Myanmar provides the care via the hospital. So this is clinical care is mainly based on the hospital. There's a 36 tertiary hospital, 8100, 150, 100 secondary creative hospital, and more than 700 hospital for private care. So but only 4 public hospitals are providing diabetes food care, and now going to be extended diabetes food care in another 3 government hospitals. So this is a government service in private care. So for the private sector, there's only 5 private hospitals providing the diabetes food assessment and diabetes food care. So all hospitals located in the Yangon economic city or the Myanmar. You can see the distribution of the tertiary hospital providing diabetes food care in Myanmar, all are central and capital city. So northern part, southern part, and eastern part are more diabetes food care hospital in there. So So this is a hospital services in Myanmar. Let's see what is going on in Myanmar primary care services. In Myanmar primary care services is very fragmented. Government primary care only supports the public activity program-based healthcare and clinical care mainly provided by private GP. Also, NGO and charity clinics are mainly provide clinical care to their Myanmar community. However, diabetes care in private care very limited. Only 4 clinics are providing the diabetes care reassessment and diabetes care to their community. All are located in Myanmar. In the government sector, there's a 30 center established by the World Diabetes Foundation, but we are not sure what they're doing, what they are not doing. Carry out how much utilization rate in that 30 diabetes care center established by the World Diabetes Foundation. So accessibility, also our government hospital provided the care to the diabetes patient is in free of services and support the drug and equipment. We also give the training and education to the healthcare staff and also patient, but we have no exact data for where we are now and where it will be. So this is indicating that we have a limited accessibility that we can get. So in the healthcare system, government services free of charge, but in the private healthcare center, we have to look for out-of-pocket money. This is made it difficult for our diabetic patient with food problems. The affordability are very poor. So you need to understand that we need to be promote our healthcare facility healthcare system. We also have to consider biopsychosocial contents and individual immunophysiology or to make the motivate and sensible diabetes care in Myanmar. So luckily we found out that diabetes food pathway delivered by the diabetes food international. So we are now going to implement the diabetes food pathway based on the hospital care. So this is a hospital care services. For the primary care services, we have to promote diabetes care education and training in the primary care practitioner. Because of we have not exact data for the how many primary care physicians are interested in providing that. But we noted that with the processing data, so most of the patients are traveling to go to the far way to get the diabetes for their problems. So we also need to empower the patient for the diabetes. We took the healthcare hospital. So we also look at the communication of the social media and technical solution. It's a very effective for the diabetes patients, and then we also need to initiate the charity diabetes care program for the very vulnerable who are very poor to get a diabetes care services in the private sector or government sector. So not only the hospital, but also in our primary care services, we had to implement the hospital pathway, collaborate with the hospital or the hospital services on the healthcare system, government services and private services of the hospital care. However, current situation very difficult to implement the proper healthcare project in the surviving for the security, and we are also trying our best to provide the healthcare, essential healthcare to the community. But we are very thankful to international using their knowledge and their products, providing medical care to our patient. So this is a understanding internet collaboration with the interdisciplinary and social relationship very important to reduce the diabetic healthcare cost and increase the accessibility to diabetic care. This is an internal within the hospital, within the clinic, between the clinic, between the hospital, clinic on the healthcare system. Private public partnership or private to private partnership to get a more accessibility to diabetic care, to reduce the diabetic food complication. So we also need to collaborate between the internet and external. External is not only that we have to collaborate with the Diabetes Society, Cancer Society, also NGO, the government organization, NGO, and social media to get the more awareness of practice involvement in diabetes care. Who needs the diabetes care to save their limb from the problems. So finally, we also approached them with international collaboration. Now we have a benefit for collaborating with the diabetes international. We also now is a member of the Asia Pacific Association for Diabetes and so we have been knowledge. Also, we have a technique, we also have institutional support, education and support, academic support on the international diabetes association. So we need to share our education and dissemination is very important. We need to share this not here. We can say our healthcare devices, doctor, also nurse and doctor, we have to be caregiver. But remember, we have to share and educate as much as we can to save them our name on them diabetes patients. So now we are following our school plan. We plan how to provide diabetes care to reduce their complication and then to save their limb, to rise their catastrophic healthcare costs for their care. Also, we had to be help each other, and then we had to be the diabetes born and diabetes care for us. Thank you so much.
Thank you very much, Professor Kim Yur-Ren. You have very good plan, and with your hard work, along with the leader by Professor Thong Min, I'm sure the diabetic food care in Myanmar will be better and better. Thank you. Also, I'm very glad to know that the fast track pathway initiated by the D-Food International is very useful for Myanmar. Thank you. Okay, Samson, are you ready? I see you on screen. If you're ready, the next one will be from Hong Kong. Samson, you're on mute. Not sure what's the problem there. Okay, maybe we move to Singapore first before the Hong Kong. Professor Ashish Nagar from Singapore, please.
Thank you. Can I share the screen? Can I share the screen? Nicoletta.
Oh, I see. Okay, what happened? Samsung Samsung is sharing the screen now. Sorry, Aziz.
Oh, okay.
That's why you cannot, because Samsung is trying to sharing the screen now. Okay, Samsung, if you're ready. Samsung, we still cannot see your screen. Samsung? Okay, I think if you're not ready, we will move to Singapore first. Aziz, please share the screen.
I can't get the screen. Ah. One moment. What happened to my slides? One moment. Oh dear.
Anyone had this experience before?
Okay, here.
Okay.
Photos
Then
were in my.
your file.
Okay, I got it now. Oh dear. Can you see?
Okay. Yes, we can see your PowerPoint now.
Okay, moment.
Okay, perfect.
For Singapore, we have a prevalence of 11%, second highest among the developed countries after USA. And it costs us about 1 billion annually and rising. Is the number 2 cause of ill health and death after heart disease. And we adopt a 2-point strategy. The most important one, strategy 1, is prevention by public awareness program, patient education, and annual food screening. And IDF has shown that such prevention programs produce 60% reduction in amputations. The key to management of diabetic foods, we feel, is prevention, as shown by BREM's data. Is only when prevention fails and food ulcer develops, then we treat this complication by a team approach combined with a clinical pathway. This is what we have followed for many years, about 20 years now, with good results. The evidence has been shown by Faglia, Driven, Larson, many others. Martinez shows that when you combine team approach with clinical pathway, you can achieve much more, from 17% to about 10%. We did this, and our results showed that the combined approach reduced LOS from 20 to 12 days, major amputation BKA from 31 to 11%. So I think combining them is the way, not just team approach. You must have a clinical pathway. We started 20 years ago, May 2000, with Dr. Chon Sokbi, my deputy endocrine. And since then, we have organized a big conference in Singapore, the 5th regional conference in 2013, and then the 20th. We'll be having the 20th soon, and that's the 10th in 2013. And strategy 1, therefore, is our bugbear. We can see that there are 2 columns. Education is 1 column, food screening is the other column, but an equally important central column remains, that is, unless you get government involvement on both these fronts, you're not likely to achieve much. And we have, fortunately, government involvement on 5 fronts: education, lifestyle, screening, control, and treatment. Education, therefore, is the key. We think it's about 90% of prevention, and food screening, perhaps 10%. Who do we educate? The patients and caregivers, 80% of our time, but who to conduct the education? The DM food team. We use education pamphlets like care of diabetes, care of the feet, choice of shoes, used since 2014 with Malay and Mandarin translations. They are published in the ASEAN guidelines if you are interested in reading them. Healthcare professional education is important, and we have written 4 textbooks for this purpose: Diabetic Food Problems, 2008, then Diabetic Food, then Surgery for Diabetic Food, and the latest one, Understanding DM Food, a guide for GPs. And this helps in training our professionals, nurses, doctors, and so on, podiatrists. When prevention fails, then the food complication or ulcer is best treated by a team approach and a clinical pathway, best run by a clinical coordinator. And by our approach, similar combined pathway, we have reduced the average length of stay from 20 to 12. The major amputation rate significantly reduced from 31% to 11%. So this approach does have a good share of success. But the challenges we face in carrying on this pathway is that we need to streamline the pathway. Ours was a bit complicated. We have below-knee pathway and one without below-knee. We are now making it simple into one. Manual pathways became obsolete as we became online. So now we are developing an online pathway that takes time, needs money, needs costs. We need to code for diabetic food. Surprising, we don't have a code. And we also need to develop a hospital registry. Once we code, the hospital registry will come. And that we think is important for future research, publications, and even work. Our new diabetic food team, Sengkang, is run by Francis Wong Keng Lin, who was my trainee, and he has now become a big consultant over there, running a big diabetic food team in Sengkang General Hospital. And while I use vascular surgeons, he uses plastic surgeons. It doesn't matter who your partners are. So long as they are passionate, you can get good results. And that's Francis with the plastic surgeons. And now he's handling more and more complicated cases, including osteomyelitis and septic arthritis. So the 2 of us, NUH, myself and Francis in Sengkang, are actually leading the way for the Singapore island. Francis has made great progress, much faster than I did, because benefited from our experience in NUH. He's reduced the below-knee amputation rate by 60%, and now starting a version 3 with interventional radiology. He's developing a CDOC clinical pathway, don't follow the mistakes that I made, manual, and developing a hospital registry at the same time. DM, one of the challenges of COVID, when COVID came, we had problems, of course. DM food team round stopped. NUH is not affected, but we have already started sit-down case presentation style. But Sengkang, severely affected, they do face-to-face rounds, and now that has been halted. Nowadays, during COVID, only emergency admissions and emergency surgery now is gone back to electives again. Sengkang General Hospital is our biggest diabetic foot team now, new diabetic foot team. Public awareness program is developed. We have a tripartite model, the hospital, the polyclinic, and the community club. The public awareness walk, community club. Public awareness talk, polyclinics, hospitals. We provide food screening and exhibition on diabetes and diabetic foot. With this model, we're slowly moving towards Changi and one of the hospitals. So simultaneously in Sengkang, we carried on with the professional awareness program for GPs, nurses, podiatrists run in the clinics and the hospitals. And a new book that I've written has been launched, Understanding Diabetic Foot, a guide for general practitioners, is to help in this professional education. We are also giving lectures to the College of General Practitioners to encourage and disseminate good work on diabetes by them. So there is a long road ahead. There are many other challenges that remains. We need to engage more international experts by the Ministry of Health, such as Keith Harding and Gary Raymond. They made such big progress for us. We also need to introduce the P&O service to provide better sugar. That is something that we are weak in, and we are slowly focusing on this. And of course, we need to engage the other latest technology as well. So in conclusion, prevention is the key strategy for the success of any diabetic foot program, and mainly by public awareness and also by annual food screening. But don't forget that professional awareness is also important. And so there are two pillars, but central, as I said, is the government force, without which we will not get much success. And because of the government involvement, through education, healthy lifestyle, screening, control, treatment, addressing for the general population is made our job much easier, and perhaps we can reach what we were dreaming for. 20 years on after the team approach and critical pathway, we have reduced A loss, of course, to 12 days, complication rate to 7%, and significantly reduced the below-knee amputation rate from 31% to 11%. Now that is a significant advance. I think getting more than that is going to be difficult. So I thank you, ladies and gentlemen, for your kind attention. Oh, by the way, we would like to invite you next year to the 20th Asia Pacific Conference on Diabetic Limb Problems in Singapore, 23rd to 24th November. There will be a two-day conference with workshop for nurses, doctors, and podiatrists. Welcome to Singapore.
Thank you
And
very
please
much.
join our association. If you're not already a member, I'm the secretary. Please write to me and join our association. Thank you.
Thank you very much, Professor Aziz. It's always great for listening to your talk. You are like a father to all of us in the region. So your experience is very precious. Thank you very much. I'm sure we all will see and visit your city in Singapore in November. So everyone, please join us and celebrate the 28th years together at the Asia Pacific Conference on Diabetic Limb Problem in Singapore in November of next year. Thank you. Samson, your hands up.
Yes. Can you hear? Can you see the presentation?
Now we can
yes,
see
yes.
it. Please.
Okay.
Go ahead.
Okay. I'm sorry about that. There's some hiccup. So I'm from Hong Kong. I'd like to present the situation in Hong Kong. In Hong Kong, it's a very small place. It's part of China. We have about 7 million populations. The diabetic foot care is mainly in the burden of the public service. About 90% of them, diabetic foot, are seen in the public hospital. Among the 40 public hospitals in Hong Kong, I used to work in one of them, so that's why I have developed my interest. I was going to share today some of the situations in Hong Kong. So the diabetic food care is primary and not just the
Samson, your internet is a problem that he could not.
effect of the lower limbs, and these
Samson, can you hear us? Samson?
or they would get life-threatening situations. So this is the problem we share in the diabetic foot ulcer. We care. The personnel involved in hospital is
We lost him. Seems like he has some internet connection problem. And maybe we move to the next speaker. Luinyor, are you ready from Philippines? Luinyor, are you there?
Yes, for a while, sorry.
Okay. I'm not sure if you can share the screen, but we lost Samson. We can see your slide now. Please go ahead.
Can you see my screen?
Yes, we can see your screen.
Okay.
Okay. Thank you.
so the orthopedic surgeon has a major role in the care of these diabetic ulcerations.
Good
The
afternoon,
education
everyone.
part,
Sorry.
the education part of the wound management education programs involves the some of the society of the Hong Kong Society of Diabetic Care, such as I am the president. So we used to work with a lot of the diabetic nurse, the allied health, and also the podiatrists. We have advanced wound management conferences. In 2019, we have the symposium on wound health and from traditional to new advanced. And such as this one in 2018, we have the organized course for the trainee and also the more personnel. And subsequent to that, we also had in 2019, we have symposium on the wound care management from traditional to new advances. We have about over 100 to attendees for these conferences, and we had a successful conference. And this year, we kept the issue of the diabetic education just last month, and we were, despite the COVID in the just in the aftermath. We have also
put your slides full screen, Samson.
yes,
A
yes.
slide full screen. They are very small.
The screen, yes.
I think his screen is different from us, so this is his full screen.
Yes.
Okay, you can keep going.
Can you see?
Okay,
Yeah.
carry on.
Yeah.
Carry on.
Okay, so we have the wound management work group presenting the under wound care nurse consultant, and they have a formation of the wound care team. And these are major workhorse of the diabetic care team of our hospitals. Now these are the staff of our society. We have the podiatrist, the PNO, and also the orthopedic surgeon myself. So we have make up protocol of the guideline for the wound, such as the pin site, the wound swab program, and also wound care referral, and also specialist consultation in case of specialist care is needed. And we have education for the personnel, but also we have community education, and also we have a community consultation. People like this, the elderly patient group can have the consultation of their food care assessment. So the wound management team since 2013 we have been working. So we have been doing that for the last 10 years, and it is now, I say, quite established among the HA hospital. The 40 public hospital in Hong Kong, they are very familiar with the wound management protocol. And we have statistics among the diabetic group patient in terms of their care, the outcome, the amputation rate, and also the survival. The wound management team in 2010 has been keeping statistics of the hospital in my hospital in the past. So we have professional. We have the RN, what they are attending. They have graduate certificate with stoma care and wound management, and we have APN, so-called advanced practicing nursing. They go to overseas for training for the food care. So these are the activity days of one of our groups in the past. We have once a year a local communities participation in the among the general healthcare of the districts. So this is the logo of our society. We are part of the Association of the Asia Pacific. So underneath that we have the Hong Kong Society of Diabetic Limb Care. So we have the website, and we have cooperation with for example, in China, in Guangzhou, this man whose company is a major company in the footwear, healthcare footwear for the population, including diabetic. So this gentleman is a friend of mine. So we have the website for diabetic limb care. So you can visit the site and read out the activity we have done in the past. Okay, I'd like to thank you, Dr. Gruber, for inviting me. So hope to see you all in future. Thank you.
Thank you very much, Samson. Finally, you made it. Dr. Samson Chan is one of the pioneer person in diabetic foot care in our region. Thank you very much. So we
okay, thank you.
Thank you. Okay, our next Runyo from the Philippines.
Good afternoon, everyone. I'm going to share my slides. So good afternoon. I'm going to share my slide So how to make diabetic food care accessible and affordable in the Philippines, and of course, eventually to the Pacific region. So as of 2016, it is estimated that around 6 million Filipinos have diabetes.
See your slide yet?
Can you see my slides?
Not yet.
Not yet.
Not yet. Samson, please.
Samson
Yes.
had to
Stop sharing.
stop
Samson,
his.
please
Okay.
stop sharing.
Stop ending. Then your
Okay.
slides. Right.
Okay. Okay.
Okay, I'm going to share my slides.
Yes. Thank you.
Can you see now my slide?
Yes.
Yes. Yes.
Okay. So as of 2016, around 6 million Filipinos have diabetes with a prevalence of around 7.1% in adult population. However, by 2030, the Philippines is projected to have about 7.8 million cases. And by 2030, it's ranked 9 in the list of countries to have diabetes. Among the complications of diabetes, those that occur in the foot are considered the most preventable, and the annual incidence of new foot ulcer in patients with diabetes is around 2.2%, with increasing incidence of 5% in 3 years. And the lifetime incidence of developing a foot ulcer is around 25%. Although the Philippine state funded public healthcare is overall a good standard, it differs greatly across rural and urban location. In the Philippines, private healthcare is more consistent. Private facilities generally have better equipment than public ones. The Philippine healthcare system relies heavily on private providers. So these are the kinds of diabetic foot we see in the Philippines, from a small one to bad foot already. And before, around 60 to 70% will end up to amputation. But the new data right now is around 40%. But in our institution, it's around 5 to 8%. So these are the contributors to the disaster situation. Number one is the lack of awareness for the diabetic patients. So if there's increase of diabetic patient, there will be increase of also of complication such as diabetic foot and eventually to amputation. And another problem before is the inadequate foot care training to the healthcare provider. Very important here, although there was orthotics before who came here, there's still lack of diabetic shoes and orthosis here in the Philippines. Although we have a school of podiatry here, a school of orthotics, still it's very expensive to have a diabetic shoes here in the Philippines. And another one is the high cost of treatments. That's why for the next few slides, I'm going to discuss regarding the healthcare system in the Philippines. So this is the organizational structure and accountability in the Philippine healthcare system. So we have the national government, then the local government, and the private sector. Wherein for the national government, this is provided by the Department of Health. And then for the rural and the local government, we have the provincial hospital, the municipal, and then RHU. And then the other part is the private sector. So looking at this one, so as I said, we have the public health facilities and the private health facilities. It is dominated by the private sector, accounting to around 60%. Private facilities in general are more expensive, but are perceived to provide better services because of the faster processing of results, more advanced equipment, and cleaner and lesser crowded facilities. These private services are used by about 30% of the population who have the capacity to pay out of pocket. Public service mostly cater to the poorer and near poor, as well as population residing in the isolated and deprived areas. Looking in this breakdown of cost in US dollar, OSMAC is a government hospital. National Kidney Transplant Institute is another private to public hospital, wherein there are some private patients also in the NKTI. And we can see here the amount of dollars spent by the patient. And in a semi-private hospital, you can see the difference, almost 5 times the difference compared to the government hospital. The healthcare expenditure is around 4.6 of the GDP of the Philippines, with per capita expenditure around $119 US, growing at an average of 15% per year since 2009. Over the past 5 years, approximately 37% of the total healthcare expenditure comes from public sources, both government as well as the overseas development assistance. And the government is working towards expanding the National Health Insurance Program, or we call it PhilHealth, in order to increase the access to healthcare system. And about 81% of the population are now covered by the PhilHealth. And the government is targeting to have a higher PhilHealth coverage. However, there's still a co-payment, and the co-payment for the patients are high, services are not yet comprehensive, and reimbursement procedure are still very complicated here in the Philippines. Through the enactment of the National Health Insurance in 2013, it provides the PhilHealth coverage to all. It is hoped that the healthcare system will become more affordable and accessible to all Filipino citizens. As shown you a while ago, one of the problems here is the very expensive healthcare system in the Philippines. So right now, it's around 35 billion is allocated by the PhilHealth. The PhilHealth program was set up in 1995 to provide affordable universal coverage. It covers the kinds of medical care, including preventive, curative, and rehabilitative services. Many workers and employees pay premiums that help support the PhilHealth, although, as I said, it's very expensive and high premium. And then it has a different membership categories based on the status, the work status, the income, and the age of the patient. So these are the different membership. We have the indigent, we have the sponsored members, and we even have the informal economy. In the Philippines, in 2019, the country reached a major milestone with the universal health care, wherein medical consultation and diagnostic testing, including the lab test, began to be covered, which is not covered by the PhilHealth. So for the strategies to prevent amputation, aside from the economy, so we are doing some education to our patient to control the blood sugar. And then if you're going to control the blood sugar and then control the DM complications, such as the diabetic foot complication. And of course, we're teaching foot care to our patient. So we collaborate to different agencies and different societies that caters to diabetic patient. And then another strategies to prevent amputation is that the education is directed to the physicians. And there's a significant foot ulcer and diabetes program wherein we educate our doctors in preventing, in screening, and early recognition in order for us to early treatment to our patient. As early as, I think this is around 1996. So we already started to have a diabetic foot care workshop, and very high expectation or very high objectives to have a zero amputation rate in the Filipino diabetic patient. As I said before, the amputation rate here is around 70 to 80% in government hospital. So we did some program, and we set up some clinic for screening, early recognition, and then we collaborate also to the shoemaker, not orthotists at that time. So we had this February 29, we have the International Working Group on Diabetic Foot. We had a conference and workshop, and then later on we went to the different part of the country from 1996 to 2006, and right now we're starting to go again to the provinces. So aside from that, we have also workshop with the diabetic foot ulcer for our patient, doctors, and then we have to standardize the care of diabetic foot patients. So the Philippine Wound Care Society eventually was put up in order to integrate the network of the different cooperating physicians and wound care teams to care for the diabetic patient. Like in diabetic foot workshop, we went to the different part of the Philippines in order to propagate the education to the patients, to the doctors, and to the other caregivers and other specialty. So during the the pandemic, we still do our education. So thank you very much, Doc, for coming to the virtual conference. Dr. Assis was one of our speaker, and in cooperation with the APDLP and POPAS, we had this global care for diabetic foot. So aside from that, we have almost every 2 months webinar during that time. And not only that, not only for the doctors, but also we had webinar for our patients. So this is the 15th day PAD awareness day for our patients. And then, so how are we going to make diabetic foot care accessible and affordable in the Philippines? So number one, as one of our problems is the high cost of treatment. So like Philippines, we're having this appeal, so probably we can also equate this to the equivalent to the other countries in order for the coverage of the payment. And then the universal health care, we can do this one also for the other expenses of the patient. And for the doctors, caregivers, and of course the other society, probably we can have these social responsibilities to educate and do some treatment to our patients. And of course, we have to collaborate with the international societies like this DFOT International, and of course the APADLP and the others international society. So in summary, we have to educate our caregiver, our patient, our doctors, and then probably we can have this PhilHealth or other equivalent to your country regarding the coverage of our patients, regarding the treatment and the other laboratory. And then, as I said, very important for us to collaborate to each other. So I thank Dr. Hari Krishna and of course to Dr. Golapar for this initiation of this webinar. And again, for the social responsibility for us. So with that, thank you very much for your kind attention.
Thank you very much, Yur-Ren. We learned a lot from you. You have been in this field for a long time as well. So the Philippines have very good system and a lot of events running all the time. Thank you. The next speaker will be Professor Yur-Ren from Taiwan. The floor is yours, Yur-Ren.
Yes. Do you see my screen?
Yes, we can see your screen.
Thanks. The committee invite me to join this good event, and I have chance to share our experience and now the situation in Taiwan and how to make diabetic foot care accessible and affordable in Taiwan. I'm Dr. Guo, and now as the honorary president of Taiwan Society for Wound Care, and I'm in charge as the chief in plastic surgery in Kaohsiung Medical University. And I think in our former speakers, they have demonstrated that diabetics actually is a worldwide problem, and it dramatically increased the number in the world, especially you look at that in our South East Asia country, and also in our West Pacific, they are increased the number. Till the 2030, there will be more than 552 million people have diabetics. And as you look at us in the past, well, our analysis in Taiwan, there's a diabetics prevalence rate, the incidence at that time. You look at that the number is total around 1.2 million people. They have diabetics, but that's the number. Actually, look at that increase gradually. Look at this line. That's the increase a lot of the spatial number is the 2012 is the around the 1.8 million people. And look at that situation. Another is estimate from our government analysis system, from the total population and prevalence, now is the more than increased as of 1.8. And look at recently, the government system look at as analyze diabetic patient. Actually, it's around the 11 to 12% in the total population. In Taiwan, we actually has the 23 million people, and you look at as the sheet has the 25,000 people. That's the 2.5 million people that have potential diabetics, and the diabetes the prevalence per year now is the 200,000 people per year that have diabetic foot problem. So the critical limb, that's the per year, is around the 50,000 per year, and that's the critical limb. The people they do the vascular intervention is per year now is the more than around the 80%. So it's the people the most need to have vascular intervention. And another analyze that in the past, this approximate the per year they have 13,000 people that diabetics admission for treated diabetic foot ulcer, and that's at that time around 10 to 30% need to amputation. So it's around the 10 to 4,000 people. And you look at that, and that's the amputation rate. Even we do some treatment and prevent to let the people understand the importance for the diabetic foot ulcer prevention. And you look at that amputation rate, another analysis is also 10 to 18%. So more is that's another also 10 to the 18.6% from 2001 to 2015. So during that period, that's the around there's a more diabetic foot patient is for male than the female. And also that's the prevalence of diabetic foot ulcer patient, the age is more in the higher than 65-year-old is above higher than the other age group. So the people, the age get older, and the population, the male people, they have a higher percentage diabetic foot ulcer and got the amputation. So that's more recently our data analysis, as you know, there's more than 2 million diabetic patients. And the diabetic foot ulcer is turned to 11%. So that's the admission caused by life-threatening diabetic foot ulcer per year. They have 20,000 to 25,000 per year admission. And the amputation is the per year. They have major amputations around the 6,700 people. And the minor amputation is 22,000. So amputation rates for the minor is around 20 to 25% in diabetic foot ulcer patient, and that's the major is 5 to 10%. And that's a major, it's a high level, it's including a below knee or above knee amputations per year. During that, they have some, in foot amputation, they have around 1.2 to 1.8 thousand people. So that's the, however, as you know, the 5-year mortality after major amputation is around 50 to 60%. So that's the more major, that's the population is also including dialysis and combined with the diabetes patient. So we follow this, the International Working Group, the guideline 2003, and mentioned that should a multidisciplinary team and should complementary treatment will be the major the treatment in the future. And in our, actually in Taiwan, that's the whole, the people, the near 100%, now is the 99.6% the people under the health insurance covered by the government. So the government requests the people, if you got a diabetic, hold the medical clinic or the medical center, the patient each year, they need to, under their covered by insurance, need to do the foot evaluation, including the sensation or the vascular evaluation, to make sure that diabetic foot ulcer problem need to early detect and prevent. And also, that's some numerous new tech. Also, if find they have some problem, they need to evaluate the TCPO2, the ABI, or even the CTA, or do the intervention to make sure they need to soon to evaluate and treatment. So such as this patient, even they come, they have a problem and need to do the angioplasty, and final, they just do the minor toes amputation and preserve the limb. And also in our Taiwan, for the wound care society, we have 3 major society in charge for this wound care, and we are conjoining program together for training the wound care for the patient, the nurse staff and the specialists, as also the doctor, to have some training course. And that's a wound education that's to improve the wound care and also clinical outcome. Each year, we focus the clinical practice guideline, education research, connect with the international care community. And also, we are recently, we start running a couple of years, we in charge the import, that's the ICW training system from Germany, and try to let all the standard nurse, not just for the wound care specialists, and also some facility and also institute for the patient care. The nurse should have such ability, and that's the knowledge for the wound care. And also, that's the government encourage the medical center or local community hospital, they establish a wound care center. That's an integrated team for the wound care specialists at a single location. That's the multidisciplinary team providing clinical service that undertaking a research in Taiwan. And we also established the wound care center. That's very important. And also there's the special population and aging increase in diabetic and vascular disease growing with the same population. So that's the wound care center. They play an important role for the wound care and also the patient education. And you look at that, our website, the system, from the different local region area, they have different, they have registration, and let the patient and their family understand which place they have more important. There's the clinic specialist wound care, they can get there and to get more if the care if they have a problem. And also that's the recently connect with this integrated healthy care system through the computer, and also this tailor conference and tailor healthy care system. And through this system, we can let the patient not just direct to hospital, and also stay their home, and also local private clinic. They also can consultant through the tailored healthy care system, and could educate the patient and local nurse staff how to care to get the optimal wound care, do not have the mistake. And so that's some workshop, the cutting edge technique have per year through the different society. They have educated from a different medical center and also community hospital. They arrange for education the nurse staff. And also, as I mentioned, as the AI now has started to in charge in our Taiwan wound care system, try to let the diabetic foot patient, they know how the severity and also how to treatment initiates, and then how to take care after that. So the government now they invest to implement long-term care, our system, try to connect the home and community-based service, and because the age get older in Taiwan population, so we try to increase our community system through that integrated healthy care delivery, not just for diabetic patient, but for the old age patient. They can now have different team to care. So finally, I want to make the conclusion is that in Taiwan, actually, we not completely reach the whole patient and for the educated, but we try to, through the holistic approach for the wound care, to educate the nurse staff, the patient, and build up the tailored healthy care system to let the diabetic education and resource patient to easy get it, and also establish the wound care clinic in or Taiwan, let the patient through the website to know where to go and how to take care. Thank you for your attention.
Thank you, Professor Yur-Ren. It's very interesting. I would love to learn more about the AI and all the technology that you use in Taiwan. Maybe next time we can discuss more. Taiwan is a leading country. You are very famous for all those technology things. So we would love to learn more from you. Thank you. Okay. Then the next person will be me. May I share screen, please? Okay. So today I will share with you about how to make diabetic foot care accessible and affordable in Thailand. So this is a simple diabetic foot cycle. We all know that it always starts with the foot complication, then end up with chronic ulcer, amputation, and then it's not only one-time amputation, recurrent ulcer and re-amputation again and again. This is what we have seen in our clinical service. And the way to approach this, the way to stop the amputation, there are many ways. We have the screening protocol. We have done a lot of education for both patients, caregivers, and also healthcare professionals. We have footwear technology that can help from prevention, healing, and then prevent re-ulceration again. And for the wound care, is a huge, big problem here in the region. Because the thing is that for the chronic wound care right now, all those things that we use for this wound care, it was so-called advanced wound care. So once it's advanced, it's very difficult to get reimbursed from the basic healthcare system. So it's a big obstacle for patient accessible to the care. For the prosthesis, it's very limited number in our region. We don't have enough number of orthotists and prosthetists, and most of the orthoses and prostheses in our region, in many countries, were imported. You cannot make it by yourself locally. So all these things that we can do, it all costs a lot of money and need a lot of attention by the policy people. And this is a study show that when the diabetic foot cycle run around and around and around, and I mean never-ending story, we can see that the healthcare cost will increase more and more and more. On the other hand, the quality of life, the function of the people become more and more disabled. So this is a big problem. And I think we all agree that the action plans need to be customized to fit in with each country context. And here is the concept idea that we draft for Thailand. It needs multi-sector strategy, and we need to work together. So I put in here Ministry of Public Health and the National Health Security Office need to be in the game. The Diabetic Foot Club of Thailand and other specialty organizations needs to be involved. We want to catch them young because we need prevention. We need to promote prevention protocol. So we need to teach since the medical schools. And the last but not least, very important part is the research. We need a lot of research to improve the care in all aspects in our region. So let me share the experience from Thailand. For the Ministry of Public Health and National Health Security Office, they are the group who make a policy. So we start working with them, and we develop the national guideline for diabetic foot care for Thailand. And then we work with the government, and finally we get the diabetic foot screening policy. So it's the policy that all diabetic people in Thailand needs to get foot screening at least once a year. And a nice thing is that once this policy announced, then it's connected to this CPG that they also announced that they create the reimbursement system for the offloading and all the wound care products. That, I mean, all the high risk group to develop ulcer, they can get a pair of foot orthoses and a pair of diabetic shoes. It can be reimbursed from the government. So this is how it all connected together. Okay, for the Diabetic Foot Club of Thailand and specialty organizations such as like I work with the Royal College of Physiatrists of Thailand, the Royal College of the Surgery. We all work together. We train many people. We train staff in-house and in local area. We not only train the healthcare professional, we also train the patients and caregivers. So we run, from our experience, at the beginning, we just set the workshop, run the workshop at the institute, I mean, at own institute at the university hospital. And we found that after 10 years, we found that it's just a one-time lecture once a year. And we found that there are not many diabetic foot clinics set up in the in the countryside area. So later on, we changed our strategy. So we work with the local people in like the countryside area, and we move our team, our speakers, and help them. So we arrange the workshop locally in the region. This way, in my experience, I found that we reach to the need of the local area more. We understand more because even I know Thailand is not a huge country like China, but in different parts of the country, the way of living is different in many ways. So this is just something I would like to share with you guys. Okay, for medical school, I myself work in medical school. So right now because again with the policy that all the diabetic people need to get screening. So the diabetic food screening protocol is implemented into the medical curriculum. So it's like a requirement that all the MD graduated from medical school need to learn about how to do the diabetic food screening and diabetic food education. And then after that, when they graduate, we will be their mentoring centers. So right now in Thailand, we have the diabetic food clinic network, as you see in this country map. And at each clinic, we also have like a coordinator person that can help us when we want to refer our patient. So this way it will improve the patient accessibility because they don't need to travel long way just to come to Bangkok. They can go to their local facilities. And with the technology world right now, we develop the telemedicine that we can connect, like just follow up for not a serious case, we can do the telemedicine with patients. We also develop lots of educational tools and distribute on the social media. For example, something like this is we develop the exercise program for diabetic foot people. You can see in this small picture, he had diabetic foot also there. So we can, they can exercise. We don't want them that, if they have diabetic foot ulcer, they cannot do exercise. That's not true. We need to encourage exercise for everyone, including the diabetic foot ulcer people. And we share the QR code so they can do all this at home. Okay, in terms of the research, these are some samples of the ongoing research we are conducting that help in improve the accessible and affordable diabetic food care in Thailand. For example, we work with the Department of Engineering, try to develop the AI system to help in the diabetic food screening. Again, the protocol that I just discussed with you, the exercise protocol. Before we launch the protocol to the public, we need to run a research to make sure that it really works. Okay, and this is another thing that we use the technology. In the past, when patients need as again from the policy, I mean, if after the screening, if patients fall into high risk group, then they will be eligible to get the insole once a year, I mean, one pair a year. But the problem in Thailand is that we don't have P&O facility throughout Thailand. So we use the technology that, like in a small hospital, they can do just the 3D scanner and then send the picture to the center, to the big center that has the P&O facility. And they can use the CAD/CAM system. This is the central fabrication system that's already implemented in the America and European countries. So we started to use this. Hopefully, if it's success, then it will improve accessible for patients. So patients can get all of this stuff without traveling a long way. For the affordable, improve the affordability. These are the sample. You can see these two look alike, but one of the pair, this pair is made by imported material, which make it very expensive. And this one, we use local material, just EVA, because we found that EVA is a huge business in Thailand. So, and this study already published, and we found that it gives the same result. So this, a kind of research like this help decrease the cost of all these devices a lot and make it more affordable for patients. So in conclusion, I would say that in order to get success, we need multi-sector strategies, and not only the strategy, because we need soldiers, diabetic foot soldiers, to make all this strategy move forward. And then should not only be in the country, it should be worldwide, because the world is so small, we can get connected to everyone easier than before. So please be united for diabetic foot. Together we will be stronger. If you think Thailand can offer anything to you, please feel free to contact me. Thank you very much. Okay, I will stop share. And then the last but not least speaker, Dr. Mai Thong Tri from Vietnam. The floor is yours, please.
Okay. Hi, everyone. Can you see my slide?
Yes, it's on.
Okay. Okay. Nice to meet all of you. Dr. Louis Tongso from Philippines, Regulapa from Thailand, Designator from Singapore, Wenden from China. Nice to meet all of you. And now we have the Vietnam topic about how to make the diabetic food care successful in Vietnam. My name is Mai Thong Tri, endocrinologist from People's Provincial Hospital. Okay, we have three parts about the contents. First of all, I would like to give a brief information about the challenge in food care in Vietnam. And the second part is about what we do in the national level to help the patient can access the diabetic food care. And the part three is about what activities we have done in the last year. As other countries, we face a lot of difficulties when we have the food care service in Vietnam. The first one is about the skill and knowledge. The general doctors or family doctor, especially in remote province, do not know how to screen diabetic foot syndrome or how to manage the disease in appropriate way. And most of diabetic nurse in our wound care nurse, so they do not how to debride the ulcer and so on. So it's very difficult for the patient have the dry treatment unless they are being in a tertiary hospital. Even in tertiary hospital, they are a failed hospital have rehabilitation teams or vascular intervention specialists, and that's the human research that we need to improve in the future. And the last but not least is about the social problems, lacking awareness from the patient. Diabetes patient often worry about the nephrology complication or cardiovascular complication, but they not worry about food care. And they have some bad traditional such as they do not wear the sandals, or they just use the barefoot when they go outside. This is very dangerous, but that often happen in our countryside. So what we have done in the national level, thanks to the collaboration between the Ministry of Health and Vietnam Association of Diabetes and Endocrinologists, in the March 2023, we have the national guidelines for diabetic food care. And I think this is very important. And this is the milestone of diabetic food care in Vietnam. Why? Because it set up the new fundamental principle for practicing and training. The first one is about the training. Now we have the unified and reliable material for train the general nurse or the family doctor in remote province remote province. And the second one is very important. The guidelines have create the fundamental food care service, including advanced dressing, wound care, technology, and so on, so the patient can get the insurance reimbursement and they save a lot of money. And this is, I think this is a very important thing. And what we have done in hospital level, we try to optimize what we have done before. We have to do a lot of activities, but I would like to introduce three important parts that we developed in the last year. And the second one is we try to utilize the new product, some local products that is effective but not expensive for the patient, that help the patient can access that service, that survives the service and with affordable cost. We use SPA structure for communication amongst nurse and doctors in the hospital, and this is very important. I think because the doctor and the nurse look the patient in the same way, manage the patient in the same way, and we can understand or communicate together in the same structure. So we can use that structure to communicate between this hospital to that hospital when we do some research and so on. And we use triple E strategies for using the expensive technology of food care, such as advanced dressing. It's about the effective way. We all know that the advanced dressing is very expensive, so we don't want to use that expensive dressing in appropriate way. We try to train the nurse or the doctor use that dressing in appropriate way. The second one is about the easy thing. And I think it's also very important because when we choose a dressing, we have to think about the patient. Most of the patient and their family members have to use that dressing when they take care of the wound at their home, so they have to easy to use, and the patient must understand how to use that dressing, and we have to educate the nurse or the family members how to use the dressing in appropriate way. And the last one is about economical way. We can utilize the dressing. For example, we change the dressing every 2 or 3 days if the volume of the wound is not too much. And the remote care booklets is very familiar with other views. We developed the booklets during the COVID-19 pandemic, and now it's also very useful. The patient can provide the useful information about the wound via the smartphone platform, and the doctor can look at that wound and give the useful advice doing something. And instead of going for a long trip to make the doctor, now we can save that money, save that research for other useful purpose, such as advanced dressing or antibiotic, and it helps the patient can access the food care service and with affordable costs. And the last one is about we try to use some local products. The calophyllum inoculum oils is very familiar with other tropical countries, such as in Vietnam, in Indonesia, or in Brazil. And this oil was proved in vivo and in vitro that it have the antibiotic activities, such as in it's against the staphylococcus aureus, and these wound healing and antibiotic properties make that all available candidates to treat infected wounds, especially in tropical areas. And the most exciting news is, you know what, is about the cost of these products. The cost of these products is under under $0.5 US. It means that every patient can access to these products with a cheap price. Okay, in conclusion, we do a lot of things in the last years, and us know that we have to do a lot of things in the future to improve our service to help the patient in the future. However, I quite agree with Dr. Gulaba. Together we stronger, and we will help the patient against the diabetic foot syndrome, and we will save the patient not just their limb, but also their life. Thank you.
Thank you very much for sharing with us your experience in Vietnam. Okay, we are a bit late from our original plan, but I think we can have like a few comments if you like. Anyone would like to share or make any comments? I mean, for the whole activities. To me, I think it's very important that we stay together and help each other, learn from each other, and we will grow together. Yeah. Professor Aziz, I see you turn on the mic.
You have used the booklets, remote booklets that we had been part of a team before. That's very useful. I think I hope other countries use that as well. It's very useful, actually.
I think it's been excellent, Galapa, to hear all the different programs. And I think it's wonderful that we can share things with each other and help each other to improve the situation. So I think it's been a wonderful session, Galapa.
Thank you very much, Professor Jefferson.
Absolutely right. And listening to the country reports, it is quite useful. I feel a lot of countries have updated and a lot of new things have come on board. So they're quite useful. Even for developed countries like us, we can learn from these new things. And I've learned quite a number of things just listening to the speakers.
Thank you. Dr. Mai Tong Tui, your hands up, please.
Yeah, when I saw your presentation, Dr. Gulaba, I see the same approach way in the Thailand, in Vietnam. I don't know, but we may have the government policy, and I think this is very important. This is the fundamental level that we have to it's the policy, government policy first, and then we have to build another block to help the patient. And the second one is about the public, about the AI, or about something like that. I think that now we have to adapt to a new technology as much as possible to help the patient, not in the expensive way, but in maybe in reliable way, or in the easy way for the patient which can help the patient approach to that technology in easy way to help the patient improve their outcome. I think it's very important how we utilize that modern technology to help the patient. Yeah.
Yes, I totally agree with you. And that's why we need more young people who grow up with all this technology like you guys. And I'm very happy to see all the new faces today. So I mean, it's so good to see that we have like volunteer group, like father to us, still in this group, and also we see young faces here. So this makes sure that the diabetic food care in our region will grow stronger and stronger forever. Yeah, thank you very much for joining us today. Okay, I guess Professor Jeff Sussman, you are the honorable speaker for us today. So please give us the last word to end up this activity, please. You are on mute. Please turn on the microphone.
Thank you, Ganapa. We face a daunting future, but I believe with the passion and the expertise and the willingness of all of the countries in our region, we can make things better. So I say strength to all of you for what you're already doing. Keep up the good work, and I'm sure in the long run we can really do a lot to improve outcomes. My message about education of children, I think, is so important, but we've got to reduce amputations as well. So I think well done, everyone, and it's been a marvelous day.
Thank you. Thank you very much, everyone. So hope to see you guys online for our next Diabetic Food Awareness Week next year, and also see you guys in person in Singapore. Celebrate the 28th Asia Pacific Association on Diabetic Living Together. Thank you and bye-bye.